Twin-to-twin transfusion syndrome is a very rare and very high-risk situation that can occur in some pregnancies, specifically in twin pregnancies in which the babies are sharing a placenta, but they're not sharing it very equally. I'm Dr. Monica. I'm a board-certified OBGYN and mom of 3, and in this video, I want to talk to you about twin-to-twin transfusion syndrome, a little bit about what causes it, what type of follow-up and what type of monitoring will be needed through the pregnancy, as well as some definitions and a little bit of talk about possible outcomes. So let's get into it. So if we want to talk about twin-to-twin transfusion syndrome, first need to cover the basis of what type of twins can this apply to. There are a lot of long words and Latin-sounding words and advanced terminology that comes to defining twins, whereas the layperson might usually use terms like identical or fraternal. Now, when it comes to twin-to-twin transfusion, there has to be a situation where the twins came from the same embryo or the same zygote, meaning they are monozygotic twins. So they were one embryo that split into 2 babies. Now this is further differentiated based on how many placentas they have and how many amniotic sacs they have. So is this a situation where each baby has its own placenta and its own amniotic sac? Or is it a situation where the babies share one placenta but have 2 amniotic sacs? Or is it a situation where there is one shared placenta and one shared amniotic sac that both babies are in? Twin-to-twin transfusion requires that there is one placenta because that is how this situation can develop. What happens is that one placenta that is feeding both of the umbilical cords to go to both of the babies ends up having an unequal distribution of the blood vessels and the blood supply in the placenta. So one baby ends up getting too much blood while the other baby ends up getting not enough blood. The terminology for having one placenta is called monochorionic. So there are 2 types of twin situations that could have this develop, and that is when we have monochorionic diamniotic, meaning one placenta, 2 sacs, or monochorionic monoamniotic, meaning there is one placenta and one amniotic sac. Like I mentioned though, the amniotic sac doesn't contribute to the twin-to-twin transfusion syndrome because that's a situation that's developing in the placenta. So once we have this situation of the unequal sharing of the blood between the 2 twins, we have a name for each of the twins. So the twin that is receiving too much blood or sequestering too much blood is called the recipient twin. It is receiving too much blood. Now this twin, it might seem like this twin might be better off because the blood we know brings oxygen, it brings nutrients. Having a good blood supply to the baby is essential for normal growth and development, but actually having too much blood can be problematic for the recipient twin. This twin ends up having something called polyhydramnios, which means too much fluid around the baby. Again, you'd think that normally this is a good thing because we know that not having enough fluid is a problem, but having too much fluid also causes problems for the baby. The recipient baby is at risk for having problems such as heart failure from having too much blood, something called polycythemia, which just means too much blood, too much red blood cells, and having something called hydrops. Hydrops is when the abnormal amount of fluid, that extra fluid that the baby has, ends up in strange areas amongst the baby's body. So underneath the skin or around the heart, unusual places in the body where there shouldn't be fluid. Now, meanwhile, our other twin who's having all its blood supply stolen away is called the donor twin. And as you can imagine, the donor twin does also have some severe problems. So this usually leads to things like having oligohydramnios, which is a fancy word meaning not enough fluid around the baby, as well as having poor growth, so being growth restricted, not able to grow to the right amount. Now, twin-to-twin transfusion syndrome is a very serious complication. I don't tell you these things to scare you or worry you if you are someone who has this situation right now with their pregnancy. These are just things to be aware of so that you can prepare and have an idea of what things we're looking out for and trying to prevent as your care team takes care of you. So either twin is at risk of having abnormal organ development, meaning things like having heart failure, kidney problems, having blindness, deafness, neurological maldevelopment, and there's also a very significant risk of premature delivery, so all of the risks that come with prematurity also apply to this situation. So how would someone be evaluated to see if twin-to-twin transfusion syndrome is in place or starting up? Once someone has been determined to have a twin pregnancy, one of the first tasks is to determine the chorionicity, which means determining how many placentas and how many amniotic sacs. Once it has been found that someone is monochorionic, meaning having one placenta, they will immediately begin having more frequent ultrasounds and specific evaluations within that ultrasound. So somewhere in the range of 11 to 16 weeks, they will be seen by a high-risk doctor doctor and have ultrasounds done to look for very specific findings. The things that will be looked at on ultrasound, and the one that first is the most obvious, is an abnormal distribution of the amniotic fluid. So if one baby has a lot of fluid around them and the other baby seems to have a small amount of fluid, that indicates that one baby is showing that sign of a recipient twin of having extra fluid, while the other one is showing signs of possibly being a donor twin and not having enough fluid. This is one of the first signs that there may be something going on with the twin-to-twin transfusion. What will also be noted is the baby size, because we know that the recipient twin tends to be much bigger, while the donor twin tends to be smaller. They will also be looking at the bladders of both of the babies. Significantly, they'll be looking at the bladder of the donor twin to see if it's continuing to be open and containing some fluid within it. An additional part of this ultrasound is something called a Doppler ultrasound. And what this does is it looks at the blood flow going through the umbilical cord and through a certain part of the brain called the middle cerebral artery to see if there appears to be adequate blood flow during all stages of the cardiac activity. So is there blood flowing in when the heart is in systole, which means it is beating, and when it's in diastole, which is in between beats? We want to see forward flowing blood towards the babies during all points of the cardiac cycle, as this indicates that there is adequate blood flow going to them at all times. Some findings that indicate that there's starting to be a problem with the blood flow would be if at certain points in the cardiac cycle there is no blood flow or there is actually backwards blood flow. So the Doppler portion of that ultrasound is what's specifically looking at that blood flow to both of the babies. And this ultrasound evaluation will be done at least every 2 weeks, if not every week, depending on the findings. The same ultrasound evaluation and Doppler is used to determine if there is a finding of twin-to-twin transfusion syndrome, what stage it is in. So there are 5 stages of twin-to-twin transfusion syndrome, with stage 1 being the most minor and stage 5 being the most severe. The initial findings that would prompt a diagnosis of twin-to-twin transfusion syndrome would be the findings of too much fluid in one twin and not enough in the other twin. And then as additional findings come up, the diagnosis or the severity of the twin-to-twin transfusion would move forward. So if we're then seeing that the donor twin does not have a visible bladder, or if we're now seeing that there are abnormalities on the Doppler portion of the ultrasound, these would be things and findings that move the stage up in the diagnosis of the twin-to-twin transfusion. And these worsen, including things like organ failure and even fetal death of one or both twins, which would qualify as a stage 5. If you're finding this information useful, please drop a like so it can help some other people find the same education. So what can be done? I've told you all the doom and gloom and the scary factors of this particular situation and things that can happen. Do we have treatments for it? And the answer is yes, we do. So the first treatment that may be offered is just expectant management. So if someone has stage 1 twin-to-twin transfusion syndrome, meaning we've just seen the abnormalities in the fluid and possibly the size, but the donor bladder looks fine, the Dopplers look fine, and everything else seems to be functioning normally, we can often just do expectant management, which is a fancy term for just kind of watch and wait and closely monitor. So this would require at least weekly ultrasounds to check all of these things that we've talked about looking in the ultrasound and watching for any sign of progression to stage 2 or further. Another treatment option is something called amnioreduction, which is when a specialist will go and place a needle through the mother's abdomen and remove some of that excess amniotic fluid that we're seeing in the recipient twin. For a diagnosis that's made further in pregnancy, when we're at a state where the babies are viable or closer to the 3rd trimester or even term, sometimes delivery is the recommended option. Let's say, just for example, that someone had known monochorionic twins, was having their every 2-week ultrasounds and everything's been looking fine. But then at 34 weeks, they were found to have stage 1 twin-to-twin transfusion. It might be something where they just watch for another week or so, or it may be something that they say, let's just go ahead and deliver these babies. We're 34 weeks. We know that there'll be some possible complications of prematurity, but sometimes that weighed against the finding of the beginning of this unusual situation with the blood supply, delivery might be considered. And it's a very vague, general discussion about that particular situation. The point is to show you that depending on the gestational age, sometimes delivery is an option. If you compare that to someone who's diagnosed at 20 weeks with having a stage 1, delivery would not be ideal because, of course, that's not a viable gestational age. Another option that is not widely available but is sometimes considered and has been considered in the past is selective reduction of one of the twins. This is an exceedingly difficult decision to make and has to be very much on an individual basis and is usually reserved for more severe cases, but this is when one twin is selectively terminated to try to spare the life of the other twin when things are looking severe. And our final treatment option, which I want to go into with a little bit more detail, is something called fetal laser therapy. And this is very advanced technology and advanced treatments where when the findings of the twin-to-twin transfusion syndrome are found to be progressing or maybe stage 2 or further, there is a specific procedure that can be done when a specialist will actually perform an intrauterine surgery where a camera is placed within the uterus and within the pregnancy, and a laser is used to block off those connections between the blood vessels that are going off to the two twins. So the idea behind this is that by blocking off where that kind of interface is between one twin side of the placenta and the other twin side, the twin that is sequestering all the blood will have an obstruction so that all the blood can't be taken over to that side and may instead be distributed more evenly between the two twins. So the official name for that type of procedure is fetoscopic laser surgery, which means the scope that's gone into the uterus of a developing pregnancy to do this fetal surgery. We can call it FLS for short. So FLS is not without risks. Of course, you're performing surgery within a pregnancy. So risks involved with this procedure include a premature rupture of membranes. There's obviously some type of penetration into the amniotic sac to make this happen. It's a very small penetration, but sometimes that will rupture the amniotic sac and cause a preterm rupture of membranes. Depending on the gestational age and how that progresses, this can result in loss of the pregnancy. Now, this procedure involves operating on the placenta. So anytime the placenta takes any type of trauma, even if it's mild or something is done to irritate the placenta, there's risk of the placenta coming off of the uterus, which is called a placental abruption. And that is one of the risks of this procedure as well. And there is continued risk of twin-to-twin transfusion syndrome after the procedure is done. There's also a risk of something called TAPS, which is twin anemia polycythemia sequence. So TAPS for short. What this is referring to is really quite similar to twin-to-twin transfusion syndrome, but it specifically is discussing how one twin is becoming anemic, meaning having a small amount of blood or a low hemoglobin, and the other baby's becoming polycythemic, which means too much blood, too much hemoglobin. So how about our chance of success for someone who wants to undergo a fetoscopic laser treatment? Based on data released by the Society for Maternal Fetal Medicine, the success rate, which means the survival of both twins after having this done, is anywhere from 50 to 70%. That's pretty decent odds considering how serious the situation is that's being treated. They additionally note a statistic of about 20 to 30% incidence where one twin survives while unfortunately one twin does not. And it does carry a risk about 10 to 20% of loss of both twins. So how about some overall outcomes? So survival of both twins is absolutely possible. As noted, even after having the fetal surgery, a 50 to 70% success rate of survival of both twins. Well, how about once they're born? Now, as I mentioned earlier, there's a pretty high incidence of prematurity. Even in a monochorionic pregnancy that has not shown any sign of twin-to-twin transfusion and that has not had any complications, the general range of recommended delivery is somewhere from 34 to 36 weeks. So 37 weeks marks term. So essentially all of these babies are being born prematurely, and premature deliveries carries risk with them. One study noted that many pregnancies after undergoing the fetal surgery end up carrying the pregnancy for 10 more weeks. And on average, a lot of these pregnancies will end up delivering around 30 weeks. There was a study that noted that many of these babies born around 30 weeks ended up being totally normal. However, there is a rate of about 1 in 5 that have shown some neurological deficits at age of 2 years old. Twin-to-twin transfusion can be an extremely stressful situation to deal with while you're pregnant. On top of all the other normal concerns with being pregnant and bringing babies into the world, this requires a lot of tedious follow-up, very frequent appointments, and things can change and be very dynamic from one week to the next. It's also very hard to predict what the outcome is going to be because there's no one situation, one outcome that applies to everybody, and as things change, delivery timing and outcome prediction can also change, and things are very dynamic. My best suggestion would be to just be open with communication with your care team, to take it day by day and just week by week, as it can be overwhelming to think about the whole pregnancy at once every day. But I will note that advances in what we can offer in medicine and fetal surgery does give us a great treatment option for this situation, and our surveillance with ultrasound gets better and better as time goes on. So as long as you're being monitored, being watched, following up as you're recommended to. So that's a rundown of some of the details of twin-to-twin transfusion, as well as what you can expect for monitoring and follow-up, and as well as a little bit of a breakdown of the different stages. I hope this helps you understand what is going on with this situation. This is a very high-risk situation and can infer a lot of stress to both mom and father of the babies and the family. So leaning on your support system is very important through this time of prenatal care.